factors for endometrial hyperplasia and adenocarcinoma. Describe pathogenesis, types, morphology, natural history of endometrial carcinoma. Describe the pathologic features of endometrial stromal sarcoma and malignant mixed Mullerian tumor. Describe morphology of myometrial tumors, leiomyoma and leiomyosarcoma. Okay? This is our objective today. Firstly, we will talk about endometriosis. All of you know what the definition of endometriosis. Endometriosis is the endometrial gland and stroma grow outside the uterus, and it is not a neoplasm, and undergoes cycle change with menstrual cycle. Even this endometriosis, just if we find endometrial stroma, just this is endometriosis. And always we found both of them, endometrial stroma and gland. And they undergo the cyclic changes. So that always the patient come and suffering from pain. Okay? And always after this cyclic change, this endometriosis may heal with a scar. The pathogenesis. There is two theories, both of them supporting with evidence. There is metastatic theory and metaplastic theory. Metastatic theory, that means this tissue is implanted by retrograde menstruation through the oviduct. Implant is spread by lymphovascular routes. الميتاستاتيك theory بتقول التشو دي implanted outside the uterus by retrograde menstruation. You know that menstruation go downward and go through the vagina and outside. Here in this theory said that there is retrograde. That means this endometrial tissue, instead of going downward, it goes through the oviduct, through the fallopian tube, and spread outside in peritoneum, ovaries, anywhere. Okay? And also, this metastatic theory said that this spread go away from the pelvis area by lymphovascular spread. This is the first theory. The second theory is the metaplastic theory. Endometrium arises from coelomic epithelium, and this coelomic epithelium is a mesothelial lining of the pelvis and the abdomen, just as Mullerian epithelium in embryogenesis. يعني دي بتقول شنو؟ بتقول إنه أساساً الإندوميتريوم ده arise from coelomic epithelium during an embryology. Here, in this theory, that means this lining, the epithelial lining of the pelvis and the abdomen, undergo metaplasia, and from mesothelial cells become endometrial.
يعني
second theory.
يعني اصلها من البلفس والابدومين.
اصلا الاندوميتريوم arise من المالاريان epithelium. المالاريان epithelium ده shared with the mesothelial lining of the abdomen and pelvis. Here in this theory, the theory said that this undergo metaplasia. This metaplasia transforms this mesothelial lining into endometrial tissue. You get my point?
Yes.
You get my point? Okay. The issue, some issues, against this theory or hypothesis, like endometriosis occur in amenorrheic women. يعني عندهم gonadal dysgenesis. هم أصلاً ما عندهم amenorrheic معناها there is no menstruation. But these ladies can develop endometriosis, and this is against the metastatic theory. For this reason, this is a hypothesis. Still, this is a hypothesis. The others say women have retrograde menstruation, but majority do not have endometriosis. في كثير من ladies have this retrograde menstruation, but have no endometriosis. Also, this again is testicle. Okay? What about the molecular mechanism in endometrial tissue? In this endometrial tissue, there is over-expression nuclear receptor, steroidogenic factor 1 and estrogen receptor beta. التشو ده لقوا انه في في اوفر اكسبريشن لشنو؟ للنيوكليير ريسبتور استروجين فاكتور 1 ولاستروجين ريسبتور بيتا. According to this overexpression, there is local overproduction of prostaglandin and estrogen. And you know that estrogen is a hormone that that enhance the growth of the endometrium. And also there is enzymes aromatase in these tissues. For this aromatase secretion, they form inhibitor for this aromatase and use it for treatment of this endometriosis. Because this aromatase that means inhibit the proliferation of this endometriosis. Application SOX2 inhibitor and aromatase inhibitor are beneficial to regress this or to treat this endometriosis. Yes.
ايش يعني عندهم retrograde بس ما عندهم
احنا قلنا في two theory. First theory said that there is retrograde menstruation. And this explains endometriosis. But this issues again is the hypothesis. Again is the hypothesis.
قالت انه في ناس يجيهم ريتروجريد بس ما يجيهم
ما
اندوميتريوز.
يجي وتحصل والاندوميتريوزس ممكن يحصل لليدي هي اساسا امونيريك يعني ما عندها menstruation have no menstruation instead of that they develop endometriosis.
طيب وش يعني retrograde اصلا؟
retrograde
يرجع.
ترجع.
يعني هي اصلا هي ما عندها اصلا menstruation.
menstruation normally go down but here there is another type of menstruation in this the way of the endometrial shedding is to retrograde against the normal downward. Endometriosis is clinical features. A lifetime risk is 10% of the women. You know that in the ovarian endometrioid carcinoma, they develop with endometriosis. So that lifetime risk is 10% of this. We may develop another from this endometriosis. Symptoms, what is the symptoms? The patient came and complaining of severe dysmenorrhea. You know the meaning of dysmenorrhea? Painful menstruation. Dyspareunia and chronic pelvic pain, intrapelvic hemorrhage or adhesion. Dyspareunia شنو؟ أيوه painful intercourse and chronic pelvic pain and even may find intrapelvic hemorrhage and adhesion due to this endometriosis. The patient may suffer from infertility and this in 1/3 of the women. May involve multiple sites. Udea is the most common site for endometriosis. The first one is the ovary. The first one is the ovary. The second one is called the sac, اللي هي area دي between the uterus and the colon in this area. And uterosacral ligament, and fallopian tube, and uretrovesical fold, اللي هي دي number 6 الاريا دي تمام. Around ligament and appendix, vagina and retrovaginal septum اللي هي دي نمبر 10 الاريا دي. في كل الاريا السيكم والابندكس والإيليا الاريا بتاعت الإيليا and inguinal canal, abdominal scar, ureter peripheral sites. This is a common site of endometriosis. This is the endoscopic finding of the endometriosis. Endometriosis of the ovary and broad ligament. Here, this is a broad ligament. And this is area, hemorrhagic area, this is endometriosis. And this is the area of the ovary, and this is hemorrhagic area, is area of endometriosis. Okay? And also, due to this cyclic pain and due to hemorrhage, this endometriosis may form chocolate cyst. Chocolate cyst. Chocolate cyst. Here. الحتة الفاتحة دي. Chocolate cyst. Due to hemorrhage. And this is the endometriosis involving the mucosa of the colon. This is a normal mucosa of the colon. This is a normal mucosa of the colon. Look at this area. This is endometrial tissue with endometrial stroma and endometrial gland. Okay? And this also, this is intestinal epithelium of the colon. This is the goblet cells. This is the goblet cells. This is the intestinal epithelium. And this is
endometriosis.
endometrial gland. Endometrial gland with endometrial stroma. With endometrial stroma. The second condition is adenomyosis. Adenomyosis, the definition is endometrial gland and stroma within the myometrium. And also it is not adenoplasm. You know that the wall of the uterus, endometrium, this is facing the lumen and myometrium and parametrium outside. Look at this area. All these hemorrhagic spots is a form of endometrial tissue that penetrate and go deep inside the myometrium. And this, we call it adenomyosis. Adenomyosis. Adenoglandomeiosis is a muscle. That means the gland entered inside the smooth muscle of the myometrium. Okay? Observing 20% of resected uteri and uterus. Bleeding during menstrual cycle lead to symptoms of hemorrhagia, dysmenorrhea, dyspareunia, and pelvic pain. Look at this picture. This is a gross, dark spots, and a large myometrium in this area. And if we see histopathology of these tissues, we found that this is the smooth muscle, elongated, cigar-shaped, smooth muscle bundle. This is myometrium. And this is endometrium. Go deep inside the myometrium with stroma and endometrial gland. The patient came and suffering from menorrhagia, excessive menstruation, dysmenorrhea, painful menstruation, and dyspareunia, pain during sexual intercourse, and pelvic pain.
يعني اليوتريس جالس يسوي انفيد لنفسه.
Endometrium بيحصل له traveling from the surface that facing the lumen to go deeply inside the myometrium. You know that the myometrium composed of smooth muscle and endometrium composed of stroma and endometrial gland. When we found stroma like this and gland like this in deep within the bundle of smooth muscles, that means this is a condition of adenomyosis. Look, this is adenomyosis versus endometriosis. Both of them composed of endometrial gland and stroma. But here, in adenomyosis, this is a traveling of the endometrial tissue to adjacent layer, here myometrium. But here there is a traveling of the endometrial tissue outside the uterus and go outside to the ovary, fallopian tube, and other areas that I mentioned before. The third lesion is the endometrial polyp. All of this we talk about benign condition. Endometrial polyp is exophytic mass project into endometrial cavity, like this one. It arises in hyperplastic condition or atrophic. So that may form from hyperplastic gland or atrophic gland with stroma, and also it is not a new gland. May have synchronous endometrial hyperplasia. May have synchronous endometrial hyperplasia and become indicative sign of hyperplasia. This is polyp, endometrial polyp. Cause dysfunctional bleeding. This patient may come with dysfunctional bleeding. Bleeding not during menstruation or even intramenstrual bleeding or menometrorrhagia or postmenopausal bleeding. What's the meaning of this? Menometrorrhagia. Menometrorrhagia. The meaning of this? No one knows the meaning of this. Irregular heavy cycle. Irregular heavy cycle. Postmenopausal bleeding, this is when it occurs in atrophic condition. Postmenopausal lady may complain of abnormal or dysfunctional bleeding. Look at the histology of this gland. This is a cystic dilated gland. Cystic dilated gland. This is atrophic gland. And also there is irregular gland within a fibrous stroma, rich with blood vessels. Rich with blood vessels. This is endometrial polyp, dilated gland, and abundant endometrial stroma with rich blood vessels, vesicle wall blood vessels. The fourth topic in this lecture is endometrial hyperplasia, one cause of abnormal dysfunctional uterine bleeding. Why we concentrate on this topic? Because it is highly significant potential for progression to carcinoma or synchronous carcinoma. Synchronous carcinoma, what does that mean?
Carcinoma.
At the same time, we have endometrial hyperplasia and endometrial carcinoma. And this always occur. So that this patient needs close follow-up or hysterectomy, even hysterectomy. Why we do hysterectomy for endometrial hyperplasia?
عشان ما يصير كارسينوما.
لأنه في coexistent مع بعض. في synchronicity between endometrial hyperplasia and endometrial carcinoma. So that nowadays, if the lady has complete life cycle or complete reproductive life, they doing for her hysterectomy to avoid to develop endometrial carcinoma. Okay? Spectrum of histopathology from low grade without atypia to high grade with atypia. This is endometrial hyperplasia classified into two, low grade and high grade. And low grade, this is without atypia. High grade with atypia. There is many classification. We will talk about it in next slide. Next slide. Nowadays, there is complex hyperplasia with atypia is high risk lesion. When we found complex hyperplasia with atypia, there is two types of hyperplasia. One of them is simple hyperplasia. The second one is complex hyperplasia. And both of hyperplasia, there is increased gland to stroma ratio. Increased gland to stroma ratio. That means the gland become abundant. The gland become abundant and the stroma become scanty. According to this, we divide it into two, either simple or complex. And even simple and complex, when they harbor atypia, we call it simple hyperplasia with atypia, or simple hyperplasia without atypia. And the second one is a complex hyperplasia. There is scant stroma and abundant gland in this complex hyperplasia and may harbor atypia, and at that time we call it complex hyperplasia with atypia. If it has no, we call it complex hyperplasia without atypia. This is the classification. The complex hyperplasia with atypia is high risk lesion that may develop endometrial carcinoma. This condition treated with progestin therapy. If this complex hyperplasia treated with progestin only, 75% persisted or recurred, and 25% developed endometrial carcinoma, unfortunately. If hysterectomy done for diagnosis of complex hyperplasia with atypia, we found that 23 to 48 women have carcinoma in resected uterus. So that this complex hyperplasia with atypia is high risk lesion. Even if treated, 75% may persist or recur, and 25% may develop endometrial carcinoma. And even when we do hysterectomy, we found that 48 up to 48 may have carcinoma in this resected uterus. That means it's a close relationship between endometrial hyperplasia and endometrial carcinoma. So take care when we found this patient with endometrial hyperplasia. Endometrial hyperplasia, what is the definition? The definition is the increased proliferation of endometrial gland relative to stroma. That means increased gland to stroma ratio. لما نقول increased gland to stroma ratio معناها زايد منه في الجلاند. هما في النهايه الجلاند دي بتكون احنا عارفين انه الاندوميتريوم ده عنده تو فيز، عنده proliferative phase وعنده secretory phase. You know that?
Yes.
Here in this endometrial hyperplasia, the gland in proliferative phase. Proliferative phase. And the proliferative phase always undergo which hormone? Estrogen. Tamam? So that this endometrial hyperplasia closely related to tumors that secrete estrogen.
مكتوب normal طيب.
What is the normal?
Normal proliferative endometrium.
No, and I think for you, there is two conditions in endometrium.
إيه.
Normal proliferative endometrium.
إيه.
Here, the gland in a proliferative phase. يعني لما تيجي تشوف الانdometrial hyperplasia وتعاين الجلاند حقت الانdometrial hyperplasia, we found that this gland in proliferative phase, not in secretory phase.
Okay.
طيب الكومبلكس والسلبي.
I will discuss next time. Associated with prolonged estrogenic stimulation and diminished progesterone influence. البيشنت ديل بيكون عندهم prolonged estrogen stimulation and decrease or diminished progesterone influence. And the patient برضه suffer from anovulation or endogenous or exogenous sources of estrogen. البرولونج استروجينيك ستيميوليشن ده بيحصل بتاني يا جماعه، بيحصل لما يكون ما في اوفيوليشن. احنا عارفين انه بعد الاوفيوليشن بيحصل شنو؟ بتتغير السايكل وبيتحول لشنو؟
بروجستيرون أكثر.
بروجستيرون. هنا الاوفيوليشن اللي بيحصل ده بيخلي التشو دي always subjected to estrogen و always in proliferative phase.
يعني صار هذه كأنها
also when
causes.
we use endogenous
causes
or
هذه.
exogenous sources of estrogen. What is the endogenous source of estrogen? You know, the exogenous source of estrogen, there is what we call hormonal therapy, hormonal replacement therapy. That estrogen may taken from outside for lady after menopause. Some of them. This is the source, exogenous source. What is the endogenous source of estrogen?
Tumor.
Tumor like granulosa cell tumor secrete estrogen.
Adrenal cortex. Maybe.
Secrete estrogen and form hyperplasia, endometrial hyperplasia, and this mentioned in ovarian tumor. Yes, last lecture. The other condition or molecular conditions in endometrial hyperplasia, you You know that BTEN is a tumor suppressor gene. BTEN is a tumor suppressor gene. When there is a mutation lead to inactivation of this BTEN, which occur in 20% of endometrial hyperplasia and 30 to 80% of carcinoma, this is an early mutation in the carcinogenesis. You know that here, this is the growth factors and this is a receptor with intrinsic tyrosine kinase activity. If there is a mutation here, or if this growth factor go in the receptor and lead to activation of this pathway, BI3 kinase pathway, and go inside sending a signal messenger into the nuclei and lead to proliferation. And this is, if it occur, normally it inhibited by this BTEN, okay? And here, when there is mutation lead to inactivation of this BTEN, that means this tumor suppressor gene not acting, so that this pathway is always working. Lead to this proliferation, lead to this hyperplasia. You get my point? Hyperplasia classification. You asked me about the classification, simple and complex. Here, this is the most widely used classification. This is the old classification, and this is the newest one. The old one, they classified the endometrial hyperplasia as simple and complex. If this simple hyperplasia not harboring etibia, we call it simple hyperplasia without etibia. If it harbor etibia, we call it simple atypical hyperplasia. If the gland become more abundant and irregular, it is in shape and the stroma become less, we call it complex hyperplasia. Just the number of the gland become abundant and the gland shape become irregular and the stroma become very scanty. In this situation, we call it complex hyperplasia. And when it harbors etibia, we call it complex atypical hyperplasia. If it is not, we call it complex hyperplasia without etibia. You get my point in this classification?
Yes.
The most current WHO classification recommends two major categories. اللي هي non-atypical hyperplasia and atypical hyperplasia, regardless if it is simple or complex. They divide it into two, either non-atypical or atypical. And it depends mainly on atipia. And also referred as endometrial intraepithelial neoplasia, the other name, which differ in appearance and their propensity to progress to carcinoma. Here, this is the simple hyperplasia without etibia. Just small round gland, to some extent in size and shape similar to each other, and there is stroma in between. يعني the amount of the stroma is more.
Similar يعني عشان كذا قلنا أتيبيا.
Here there is no etibia. In this there is no etibia. This is simple. Always the simple hyperplasia without etibia. In my practical area, always the simple hyperplasia is always not associated with etibia. But some of them harbor etibia. At that time we call it simple hyperplasia with etibia. And nowadays the WHO classified into two, either atypical or non-atypical. This is a simple hyperplasia without etibia. Just there is increased gland to stroma ratio. And this is the normal proliferative endometrium. Normal proliferative endometrium, round gland like this, and abundant stroma. But when they develop hyperplasia, the gland number become more. So that we call it hyperplasia. When there is average amount of stroma, we call it simple hyperplasia. When there is scant stroma, an abundant gland, an irregular shaped gland, as either branched and budding like this, we call it complex hyperplasia. Complex hyperplasia. Here, there is no atipia. There is no atipia. More overcrowding and branching. Yes. And this is less, very less stroma in between. The gland is adherent to each other, and they harboring this feature of atipia. This is the mitosis. This is the mitosis. This is the mitosis. All of this is the mitosis, and increased mitosis, and the cells become round. And here there is basally located, but here there is not. There is overcrowding even, there is overlapping of the nuclei, and the hyperchromatic nuclei, and there is some feature of pleomorphism and increased mitosis. All of this is atypical features. Okay? And this is a complex hyperplasia with atypia. And nuclei is large, and there is pleomorphism. If we talk about endometrial carcinoma, 7% of all invasive cancer in women, this endometrial carcinoma represents 7% of all invasive carcinoma in the women, if exclude skin cancer. There is 39 new cases per year in the United States versus 11,000 cervical cancer. If we compare endometrial carcinoma with cervical carcinoma, we found that endometrial carcinoma, their incidence rising, but the cervical become lower. Why?
Pap smear.
Pap smear. For screening and discovering earlier lesion before transforming to cervical carcinoma. For this reason, the incidence of endometrial carcinoma become higher than cervical. For other reasons, the new modalities to discover the carcinoma area also, ultrasound, any radiological imaging, any follow-up like this. Mainly, endometrial carcinoma occur in postmenopausal women. If there is a woman came to you after age of 55 or 60, after they stop their menstruation, and after this came and asked you, I have menstrual cycle. Always thinking about this endometrial carcinoma. Always. And the first option in your mind, you have to be the endometrial carcinoma. If it is polyp or if it is other lesions, this is not a problem. But if it is carcinoma, it is a problem. So that if the lady about 60 or 55 years old came to you at a clinic and said to you, I have menstruation after 2 or 3 or 4 years from stopping the menstruation, this is indicative of endometrial carcinoma. Usually present with dysfunctional uterine bleeding, allowing early detection and cure in majority of cases. يعني هي لأنها جينية dysfunctional uterine bleeding, lady notice that they had a menstruation after 3 or 4 years of stopping of cycle. This is sign, signal. So that you and he and she, they discover this earlier. And this is a chance to cure earlier. 2 broad categories based on clinical pathological study and molecular features. The endometrial carcinoma divided into 2 categories, type 1 and type 2, according to clinical pathological studies and molecular features. This is 2 categories of endometrial carcinoma, type 1 and type 2. From the start, type 2 is aggressive, has poor prognosis. Type 1 is this, from the start. According to the age, type 1 by 10 years. Here, the age 55 to 65, here is 65 to 75. According to the clinical setting, what is the risk factors that lead to this type 1 endometrial carcinoma? Unopposed estrogen. Unopposed estrogen, يعني الاستروجين مثلا زي ما قلنا endogenous estrogen from tumors, anovulatory cycle, menstruated, like this. Unopposed estrogen, even exogenous estrogen, obesity. obesity يا جماعه الفات تشو الاندروجين ممكن يتحول لشنو؟ لاستروجين. فالاوبيس lady always if they had an androgen, all of us have androgen. We know that the female have androgen.
Yes.
This androgen may transform into estrogen in fatty tissue, so that this lady has a risk factor to develop endometrial hyperplasia or endometrial carcinoma. Diabetes and hypertension also associated with endometrial carcinoma type 1 and mainly type 2 diabetes.
كلهم يصيرون من بوست ميني باز صح؟
Yes, the age is 55 to 65.
Okay.
This is the age of menopause, 55. So that mainly all this condition occur in post-menopause.
Okay.
Here, the type 2 always occur in uterine atrophy. And this lady, 65 to 75, has uterine atrophy. And thin physique, and this is thin lady, it is not obese lady. She is not obese lady. Histopathology. Type 1 is endometrioid, resembling different endometrioid. Type 2 is serous, clear cell, mixed Mullerian tumor. All of this is high-grade malignancy, serous, clear, and mixed Mullerian. And precursor lesions at type 1, the precursor lesion is hyperplasia as we talked before. يعني الانdometrial hyperplasia هتديني شنو؟ هتديني type 1 endometrial carcinoma اللي هو الانdometrioid type. Here, the type 2 also there is a precursor lesion, we call it endometrial interepithelial carcinoma. Okay? Molecular genetics. The molecular genetics, the big difference between them here B53. B53 in type 1 occur late and occur in a poorly differentiated tumor. And this is the late events. But here in type 2, B53 occur earlier. And 90% of the serous carcinoma have this B53. Okay? In type 1 endometrial carcinoma, there is a molecular genetic mutations like PTN mutation occurring 30 to 80%, and BIK3CA mutation in 40%, KRAS mutation 25%. Also, type 1 endometrial carcinoma is always associated with microsatellite instability. والmicrosatellite instability دي يا جماعة occur in other condition like in GI.
GI?
Colon cancer, non-purposis hereditary non-purposis colorectal carcinoma. Okay? اللي هو Lynch syndrome. And the association with Lynch syndrome. Here, as we said before, B53 in the area and aneuploidy and BIK3CA mutations. And biologic behavior. Type 1 is indolent, has a lymphatic spirit, but it has a better prognosis. Here, type 2 endometrial carcinoma, it is aggressive tumor, intraperitoneal seeding, and lymphatic spread early stage, and it has a worse prognosis.
دكتورة
Yes.
مو بالاندومتريال انترابيثيريال كارسينوما يجينا من الهايبربليزيا بعد؟
لكن دي غير عندي. دي بتجيكي بشكل السيرس نزمل السيرس هنشوفها يعني دي غير اللي احنا اتكلمنا عنها في الاتيبيكال هايبربليزيا غيرها. دي بتكون شكل السيلز سيرس هنتكلم عنها. endometrial carcinoma type 1 اللي هي endometrioid adenocarcinoma came with polypoid exophytic mass or flat lesion spreading diffusely on endometrial surface. تمام؟ polypoid exophytic mass or flat lesion spreading diffusely on endometrial surface. 3 grades, grade 1, grade 2, grade 3. And they grow by direct myometrial invasion with potential for extension into periuterine structure like the ligaments, ovaries, bladder, and rectum. يعني they grow direct invasion to the myometrium. The prognosis related to the depth of myometrial invasion. The prognosis depends on the depth of myometrial invasion. If it go deep in myometrial layer, it becomes worse prognosis. If it becomes 1/3 of the myometrium, it is become better prognosis. Become better. Complete staging operation required if tumor in outer half. Hysterectomy and salpingo-oophorectomy if inner half only. What that mean? If the tumor in inner half of the myometrium يعني في النص اللي داخل الميومتريوم بعمل البيشنت ده hysterectomy and salpingo-oophorectomy. نشيل اليوترس، نشيل الفالوبيان تيوب والاوفري. If it was in outer half يعني خلاص go deep and even reach the outer half of myometrium, that means they may need complete pelvic operation. يعني you need not taking only his uterus and ovaries and
ايش في زيادة؟
all of the tissue surrounding.
يعيش الإنسان؟
Yes, to make a good staging. If this tumor go outside in the myometrium and reach the outer half of myometrium, they need to take more than uterus and fallopian tube and ovary. We do imaging studies and we reach for metastasis to take all of this. And after that, the patient responding to chemo and radiotherapy. It's a major operation. Development of type 1 endometrial carcinoma, it starts with this mutation. First mutation occur, PTN, then transform this endometrium from proliferative phase to single hyperplasia. يعني an early mutation that occurs is PTN. After that, they harboring mutation in microsatellite instability genes, MLH1, they form complex hyperplasia. And after that, they harbor or they get KRAS mutation and microsatellite instability, and they get complex atypical hyperplasia. And after they harbor beta-catenin and BIK3 CA mutation, they become grade 1 uterine endometrioid carcinoma, and at this stage they penetrate into the myometrium. Okay? And this is the development of type 1 endometrial carcinoma arising from hyperplasia. The most common molecular genetic alteration is shown at the time they most likely to occur during the progression of the disease. Yeah, this is the sequence of mutation. Let us see the grade of endometrioid carcinoma. This is the gross features of endometrioid carcinoma. They fill the endometrial cavity and they go deep into myometrium. Histologically, this is the grade 1, this is the grade 2, and this is the grade 3. What is the difference? In grade 1, more than 95% gland forming. Grade 1, all of the tumor forming gland. Most of them, more than 95%. It is a gland. Grade 2, just Grade 3, more than 50% is a solid sheet. You get my point? Firstly, grade 1,
Gland.
most of the tumor forming gland, the grade 1. Here, the gland become 50 and the stroma become, the solid sheet become
Less than
50-50. But the gland is more than this is grade 2. Grade 3, the solid sheet become more. The gland become less. That means when the tumor forming solid sheet, that means the grade become worse. This is a fungating mass arising in the endometrium and it go deep in myometrium, and this is a grade 1, grade 2, and grade 7. Let us talk about development of type 2 endometrial carcinoma. As we said before, it is a serous, clear cell, or mixed biliary carcinoma. Here, always type 2 develop or occur in atrophic endometrium. Lady above 65. All lady above 65, they develop atrophic endometrium. And here, after getting P53 mutation, aneuploidy mutation, they develop what we call endometrial intraepithelial carcinoma. But it's not like atypical endometrial hyperplasia as we said before. You get my point here? I said that this is endometrial intraepithelial carcinoma occurring in atrophic endometrium, not like atypical hyperplasia. Okay, this is different. And here, this is become after getting P53 mutation. And they have all features of it, but still within the endometrium. Within the endometrial line. Here, after that, they form serous carcinoma. Serous carcinoma. Here, they form papillary structures like this and invading the myometrium. And always it is high grade. The serous is always high grade with bizarre shape, polymorphic, mitosis, all of this, and forming biliary structures.
دكتورة الاتروفي طبيعي تصير بعد المينوبوز.
Atrophy طبيعي. Normally it occur after 65 years. That means there is no estrogen, there is no hormones, so that the lady develop atrophic endometrium.
يعني دائما بعد المينوبوز تصير الومن عرضة للكارسينوما صح؟
Yes.
طيب ليش ما تشيل اليوترس؟
Sometimes
ايش؟
لو هم ممكن تعيش ما always ممكن تعيش بالزاوية.
هو الحين صار ما له فايدة يعني
قبل
قبل
الكانسر ده انت ما cannot expect it. If it is not familiar cannot expect it. يعني أنا مثلا I get 65 years old but I do not get mutation. Why I exposed to this large operation and doing hysterectomy? No. No one know who is get mutation.
بس أنا ما أدري إذا أنا عندي
No one.
مو
But
بسهل
if you have a family history or if you have a mutation in your families, there is indications that may expose or subjected to this hysterectomy. But if not, you cannot guess who in population they will get these mutations. Because I cannot do hysterectomy for all population. Biologically, it's aggressive. This serous carcinoma, biologically aggressive, has extensive proteinuria metastasis, may be present despite the superficial endometrial carcinoma. يعني, that means may confine to the endometrium and myometrium, but they forming distant metastasis. Extensive proteinuria metastasis. Although it is a superficial endometrial carcinoma. That means this tumor has a propensity to form lymphovascular invasion area, suggesting spread by lymphatics or oviduct area in its natural history. Let us histology of this type 2 endometrial carcinoma. Firstly, this is intraepithelial neoplasia. Intraepithelial neoplasia. اللي هي بقول عليها endometrial intraepithelial neoplasia precursor to serous carcinoma showing malignant cells. This is a malignant cells with morphologically is identical to serous carcinoma lying in the surface of the endometrial gland without obvious stromal invasion. This is the malignant serous cells, but there is no invasion. At this stage, we call it endometrial intraepithelial carcinoma. Okay? They harbor area in the state B53 mutation. So that when we do immunohistochemical stain for B53 mutation, we found this brown color in intraepithelial carcinoma. Okay? This is strong diffuse of expression of B53 detected by immunohistochemical stain in endometrial intraepithelial carcinoma. It's the same area of B53 colors, brown color. C is a serous carcinoma of the endometrium with papillary growth and consisting of malignant cells with marked cytologic edema. Nuclear cytoplasmic ratio is very high, hyperchromasia, and atypical mitotic figure, all of these features. And D is immunohistochemical stain for this tumor showing B53
in a nucleus.
B53 mutation. Okay? I think this is the sixth topic, malignant mixed Mullerian tumor. From its name, it is a malignant. Mixed, that means there is two components. The epithelial component, it is a malignant, and we call it carcinoma. And the stromal component, which is also malignant, and it's called sarcoma. So that's the name of this tumor is carcinosarcoma. Carcinosarcoma. And we call it Mullerian. Mullerian related to the Mullerian epithelium of the female. Definition. Both endometrial and stroma are histologically malignant, and we call it carcinosarcoma, arise from malignant transformation of single epithelial cells. خلينا نتكلم عن النقطة دي. إنه التيومر has two components, both of them are malignant. The stromal component, we call it sarcoma, and the epithelial component, we call it carcinoma. But what is the origin? From which it arises, from epithelial or from stroma? It arises from the epithelium. But after become malignant, it differentiates into two features. Into epithelial, اللي هي co-forming malignancy, co-forming carcinoma as usual, and also it has ability to differentiate to sarcomatous cells. اللي هم heterologous differentiation, and this epithelial cell become malignant and it become carcinoma, and also it has ability to differentiate to the sarcomatous component. يعني forming rhabdomyosarcoma, osteosarcoma, leiomyosarcoma, all of these types of sarcoma can differentiate because it become malignant. But the origin is the epithelium. This is the aberrant differentiation due to malignant neoplasm. Occur in postmenopausal women present with bleeding and 5 years survival rate, only 25%. That means it has poor prognosis. Always, grossly, it becomes polypoid, presenting as polypoid mass projecting from the cervical os and go outside even into the vagina. This tumor is bulky and go from the endometrium and go through the vagina and even may protrude outside. Very large tumor. And here, this is histology of this carcinosarcoma. This area is carcinoma. Okay, this area is carcinoma, malignant gland. And in between, this is the sarcoma. In this area may see the rhabdomyosarcoma, leiomyosarcoma, even any sarcomatous component. Osteosarcoma may appear in this area, stromal or sarcomatous areas. A sarcomatous component هي malignant stromal cell between the gland and هي areas دي كلها malignant stromal cells. ممكن تعمل لي osteosarcoma، ممكن تعمل leiomyosarcoma anyway. Let us talk about adenosarcoma. Adenosarcoma is a tumor arising from endometrial tissue. Endometrial tissue. Okay? A definition: it is a malignant stroma with benign glandular component. Adeno, and that means it has a glandular structure. Sarcoma, that means the stroma becomes malignant. So that this tumor is composed of two components also, but the glandular structure is benign. It is not malignant. Okay? Stroma is a sarcomatous malignancy. Definition: malignant stroma with benign glandular component must differentiate from benign endometrial polyp. يعني هنا لازم نعاين الستروما عشان تديفرنشيت بينه وبين الاندوميتريال بوليب. احنا قلنا الاندوميتريال بوليب فيه ستروما وفيه اندوميتريال جلاند. لكن الستروما of the polyp is benign, but here the stroma is malignant. We found here the feature of polymorphism or feature of atypia with increased mitosis. They came with large polypoid growth, carrying early age, 30 to 50%, it is a low-grade malignancy, and it is estrogen sensitive cells, and so that they doing for this patient oophorectomy to get off of estrogen. Here, this is benign endometrial polyp. Benign endometrial polyp. The stroma of the polyp is benign stroma. There is no polymorphism, there is no mitosis, and also the gland looks normal. Like the gland here, also this gland looks normal. There is no feature of anemia. But the stroma of the adenosarcoma here is polymorphic, large cells, not like this is benign, this is ovoid, and this is polymorphic cells. Some of them is small, some are large, and there is mitosis, increased mitosis. All of this is a feature of malignancy. So that this stroma is malignant and this stroma is benign. But the glandular structure in both lesions are benign. Endometrial stromal tumor. Endometrial stromal tumor. That means this tumor arises from the endometrial stroma. Okay? Definition: it is a neoplasm composed of endometrial stromal cell. No epithelial component. Here there is no epithelial component. The classification: benign stromal nodule versus endometrial stromal sarcoma. And the two conditions: endometrial stromal tumor here either انها تكون stromal nodule حاجه benign ولا تكون endometrial stromal sarcoma. في two conditions. اللي هما الاثنين composed of endometrial stroma. One of them we call it stromal nodule. It is not just nodule. Okay? The other one is the endometrial stromal sarcoma. Okay? But both of them lack epithelial component. Stromal nodule is demarcated nodule of stroma in myometrium and does not invade the myometrium. Just nodule reside in the myometrium, well circumscribed, but not invade the fascicle of the smooth muscle of the myometrium. Just nodule of endometrial stroma. Okay? Well circumscribed, forming a nodule. Not like adenomyosis, penetrating and invading the myometrium. The other lesion is endometrial stromal sarcoma. Endometrial stromal sarcoma, it is a low grade, may invade the lymphatics. This is a lymphatic vessels lined by endothelial cells, and this is stromal sarcoma inside the lymphatic vessels. And it is mitotically active and prone to recur. And 5-year survival rate is 50%. The endometrial stromal sarcoma. Tumor of the myometrium. Leiomyoma, and the other name is fibroid. All of you, I say here about this leiomyoma. And this is a benign neoplasm of smooth muscle cells located with the myometrium and rarely involve the lower uterine segment, cervix, and uterine. يعني ممكن تحصل في اللور segment, the uterine segment ممكن تحصل في السيرفكس even تحصل في uterine segment لكن rare. Okay? Most common non-skin neoplasm in women. 50% of women have at least one, and often clinically silent. 50% من الwomen ممكن يكون عندهم fibrosis, بس clinically silent. Estrogen supported undergo atrophy post-menopause. These lesions may undergo atrophy post-menopause and may flare up and grow during pregnancy. Okay? And clinical presentation may become asymptomatic, which is common, and may cause dysfunctional uterine bleeding. Some lady came and complaining from spot bleeding in between the menstruation, like this, or even may came and complaining of menorrhagia. Menorrhagia, if it is sub-endometrial or submucosal, may cause menorrhagia. Urinary frequency, if it is large and compressed, the bladder may patient come and suffer from this urinary frequency. Impaired fertility, cannot get pregnant because the implantation at this site is very difficult. For this reason, there is impaired fertility of the lady, common lady. Increased risk of spontaneous abortion, fetal malpresentation, and postpartum hemorrhage. All this condition occur due to this fibroid. The patient may get spontaneous abortion, failure to implantation of the placenta, so that this may lead to abortion, repeated abortion, because the surface area of the endometrium filled with this myometrial tumor, leiomyoma, or fetal malpresentation. يعني الفيتس ما يقدر يقعد بطريقه كويسه ليه؟ لانه في تيومر وهم بيكونوا very hard و sometimes very large, so that they form fetal malpresentation. And postpartum hemorrhage. I said that during the pregnancy, this fibroid enlarged and harboring blood vessels and may lead to postpartum hemorrhage. This is leiomyomata, multiple leiomyomata, and this is a uterus bisected into two, the one part above and the other part below. And this is the cavity, endometrial cavity. And this is a multiple leiomyomata. Small one, small one, small one, bigger one, bigger. At this side, we call it submucosal. At this side, we call it submucosal, and at this side, we call it subserosal. Subserosal. Okay? Multiple leiomyomata, bisected uterus, subserosal, and this one intramural. Intramural, submucosal, subserosal. And here, this is a multiple uterine fibroid. This is endoscopy picture from outside, okay, of the uterus. This is a fibroid, this is a fibroid, this is a fibroid, this is a fibroid. And all of them are subserosal. Subserosal, from outer side or outer side of the uterus. A lower part, this is the histology of fibroid. Here, this is the smooth muscle cell, cigar-shaped nuclei in bundles of smooth muscle, interlacing bundle of smooth muscle. And here, well differentiate spindle cell with fibrillar cytoplasm and hyalinizing stroma. This area we call it hyalinization. Reddish areas. The last tumor is leiomyosarcoma. It is very rare, prone to decay and metastasizing hematogenously, may go to lung, bone, and brain. A 5-year survival rate, 40%, and peak incidence is 40 to 60 years. Malignancy determined by magnetic figure, cellular edema, and resonational necrosis. Yeah, that means it is not arise from leiomyoma. It arises de novo, okay, from smooth muscle of the myometrium. And I determined that this is the malignancy according to the cellular edema, according to the mitosis. If I found cellular tumor like this, and I count the mitosis, and I found that the mitosis is more than 10 per 10 high power field. Per 10 high power field, I found that there is more than 10 mitosis, that means this is leiomyosarcoma. If I found cellular epithelium with 5 mitotic figures in 10 high power field, I decide that this is a leiomyosarcoma. There is other leiomyoma that is may confuse with this leiomyosarcoma. Why? Because there is other type of leiomyoma, the cellular leiomyomata, and it is a benign, but it's cellular. Some of them is mitotically active and mitosis high. عشان كده the cut point between the leiomyomata and leiomyosarcoma depend on cellular epithelium plus mitotic figures. If I found cellular tumor with mitosis more than 10 per 10 high power field, that means leiomyosarcoma other than leiomyomata. If I found cellular epithelium with only 5 mitotic figures in 10 high power field, that means it's leiomyosarcoma. Okay? Arise de novo from myometrial or stromal precursor cell. No evidence leiomyomata to transform into sarcoma. No evidence. Just see this one. This is the leiomyomata, whitish colors, well scan, and this is the hemorrhagic necrosis. And also the most important indicative of malignancy, the presence of necrosis. If I found cellular epithelium, mitosis, and necrosis, this means this is leiomyosarcoma. In leiomyomata, I didn't find necrosis. May found hyalinization, but I didn't find necrosis. If it harbored necrosis with cellular epithelium and mitosis, that means it's leiomyosarcoma. Okay? I think this is the last one. Thank you for listening.